My topic for today is hepatitis C with title and update. When I was preparing for this presentation, I realized that this is very wide spectrum, this is a very wide topic, and to fit 15 or 20 minutes, I had to choose some subtopics of this very wide topic, hepatitis C. And my election was just to treat just to talk with you about the treatment of naive patients. I will present you the new recommendations for treatment on naive patients with HCV infection, and as well I will discuss with you the treatment of DAA relapsers. The first slide summarizes the treatment options which are available right now at the beginning of 2018, and you can see just the two parts of this slide. The first part is just the beginning of the great revolution in the treatment of hepatitis C, which has begun at about 2010-2011 with the introduction of boceprevir and telaprevir, like the first generation protease inhibitors into the treatment of hepatitis C into the market. These drugs entered the market in about 2012 in Czech Republic. All other drugs which are listed in these boxes are drugs or combinations of drugs, combinations of compounds which are HCV genotypically specific. So it means that for different genotypes, we had to use different combinations, different drugs, different antiviral combinations. In 2017, the first pan-genotypic drug, the first pan-genotypic combination entered the market, and this was followed by the other two combinations which entered the market in 2018. So I call this time point 2017 like the beginning of second phase of a great revolution in HCV infection, and I will focus on these new available drugs or combinations. The first combination is a combination of glecaprevir plus and pibrentasvir. Glecaprevir is a NS3/4A protease inhibitor, which is combined in one pill with an NS5A inhibitor, which is called pibrentasvir. And this drug, I will not go in details, then this drug is right now approved for the treatment of naive patients with liver cirrhosis, as well as for the patients without liver cirrhosis. For cirrhotics, the treatment duration is 12 weeks. For non-cirrhotic patients, the treatment duration is only 8 weeks. And this drug is also approved for the DAA relapses or DAA failures, but I will not go in details in this subgroup of patients with this for this combination. I will focus just on the treatment of naive patients with gleca and pibrentasvir combination. This slide summarizes the registration trials which form the data basement for the recommendation for naive patients. There are listed 4 trials, Endurance 1, 2, and 4. You can see the target population. This is the non-cirrhotic patients with genotype 1, 2, and 4 to 6 patients with or without interferon experience in these 2 trials, in all 3 trials with HIV co-infection, which were permitted into Endurance 1 clinical trial. And the last one is Surveyor 2 study, which is just the only one trial in the phase 2 which was used for this analysis. Also with or without experience and non-cirrhotic patients. These trials were designed, as you can see on these bars. The treatment duration was 8 weeks or 12 weeks in the Endurance 1 clinical trial. The next slide shows you the results, and you can see that the results, the SVR rate, which is 99%, was almost the same without any significant difference between the arms with treatment duration 8 weeks or 12 weeks in all endurance trials. So the 8 weeks is the scheme, is the treatment duration which was chosen for the treatment of naive patients because it's clear it's quite cheaper than the treatment duration 12 weeks. And this is the reason why this was the scheme which was chosen for the recommendation. I have to say that this is interferon-free and ribavirin-free regimen. So ribavirin was forbidden in this recommendation as well. So we can proceed to Surveyor 2, part 4, which is the little bit different study among patients with genotypes 2, 4, 5, and 6. So genotype 3 was excluded from this clinical trial. And you can see the MITT, which means modified intention to treat analysis. It means that the patients with virological response, virological relapse were included into the analysis, but all other relapsers, due to reasons other than virological relapse, were excluded. And you can see that overall efficacy was as well 99%, with just one difference in the genotype 2 in comparison with all other genotypes. Be careful because there are only small numbers of patients in these genotypes, which are rare in Central Europe region. So this is just a particular information. This slide shows you the results of the same combination, glecaprevir, pibrentasvir, among cirrhotic patients, among more advanced patients with liver cirrhosis, which was defined like based on the liver biopsy or finding on non-invasive measurement of liver elastography. And you can see that all patients that all patients, overall efficacy was 99%, with 100% among the patients with most prevalent genotypes in our region, genotype 1 and 2. So the difference, the only one difference between patients with liver cirrhosis and without liver cirrhosis is not the efficacy, it's almost 100%, let's say, but the duration of the treatment. This is the regimen of 12 weeks treatment for liver cirrhosis, 8 weeks for patients without liver cirrhosis. So the question is, ladies and gentlemen, if these very nice results were implemented in some kind of international or even national recommendations. And I'm going to present you the recommendation, the first recommendation with glecaprevir pibrentasvir combination mentioned, and this was a recommendation by American Association for Study of Liver Disease, which was published in the late of 2017. And you can see the recommendation is very simple, much simpler than ever before. And you can see that GLEPIP combination is recommended for all genotypes as a first option, for patients with no liver cirrhosis, pre-cirrhotic stage of liver fibrosis, 8 weeks, and from compensated liver cirrhosis for 12 weeks. So this is very simple, and this is a very this is the first recommendation of pan-genotypic drug recommended in any international guideline. So this combination is available in Western Europe and in European community countries. In Western Europe, especially, for instance, in Czech Republic, the combination is right now under the negotiation with the payers. What is new, and what about the patients with DAA history, with DAA experienced patients? This is a quite low group in numbers right now, but the number of patients will definitely be increasing in near future. This is a very nice analysis which summarized the relapse rate among patients with genotype 1 based on clinical trials and real-world data. You know, all of you know that a lot of real-world data have been published already. And the relapse rate is something about 5%, let's say, without a difference to the genotype, to the treatment regimen which was used in genotype 1. And what is quite strange right now in the era of DAA is that the relapse rate among patients with genotype 3 is almost doubled than it is almost twice as high as in patients with genotype 1. So we can say that genotype 3 was proved to replace the genotype 1 at the position of difficult or most difficult to treat genotype from the interferon era. Interferon era, genotype 1, especially genotype 1b, was the most difficult to treat patient genotype of HCV, and it was replaced by genotype 3 in interferon era. It has many reasons, virological reasons, many reasons in the structure of the viral proteins which are used by the virus in its life cycle. Very important question is, what are the most common reasons for relapse after DAA treatments? And I have to say that at least 2 reasons are, let's say, physician dependent, and we should do everything what we can to avoid these reasons. And this is the inappropriate treatment regimen. So for different regimens, like for different genotype, different treatment regimens. So sometimes we are facing the patients which were treated with wrong regimen based on their genotype. And sometimes even we are facing the patients with an appropriate initial treatment duration. As I said, 12, 8 weeks. You can remember even longer regimens, 24 weeks from the past, etc., etc. So we should do everything what we are able to do to avoid these wrong indications in our future practice. What are the regimens available for the treatment of DAA patients? There are 2 of them at least right now. The first one is a combination, once again, glecaprevir plus pibrentasvir. But you can see that the indication or approved indications for this regimen are quite complicated. And that's why I will skip these indications for this regimen, and I will focus on this, the only one triple combination which is marketed right now. And you can see that the indication for treatment relapses, DAA relapsers, are much more simple than in the previous regime. So I will discuss with you the combination of sofosbuvir, velpatasvir, and voxilaprevir. Voxilaprevir is a new compound. It's a second generation or third generation protease inhibitor, NS3/4A protease inhibitor. These are the registration trials for this regimen. You can see 2 trials, Polaris 1 and Polaris 4, and you can see the target the target population, genotype 1 to 6, and the first Polaris 1, NS5A inhibitor experience, which is the crucial criterion for inclusion into this trial, because every drug can be reason or can develop resistant variants which are different between or among the different drugs used for the initial treatment. And the same indication, the same target group for the Polaris 4, but no NS5A inhibitor experience. That's what I'm talking about. And also patients with or without liver cirrhosis were permitted to enter this trial. And the other difference is that this was a double-blind, placebo-controlled trial. This was just there was not a placebo arm, there was an active control, so the patients were treated with triple molecule, triple combination, or just a double combination, sofosbuvir plus velpatasvir, epclusa. On the right side of the slide, you can see the percentages of any other DAA is used for the initial treatment. So this is very, very like a heterogeneous population in regards of previous treatment. But the results are homogeneous. You can see that overall treatment efficacy, the SVR rate was 96%. This is the IT2 analysis, and you can see just only let's say 7 relapsers or 7 failures due to virological reasons. 3 others were or should be excluded from MITT analysis. The efficacy among patients without liver cirrhosis was 99%, and there was no any virological relapse or virological reason for treatment failure. Among patients with liver cirrhosis, the treatment efficacy was 93%, with 7 relapses due to the virological reasons. And you can see, you can check the SVR rates regarding each genotype, and there is at least once again at genotype 3, the lowest efficacy, about 95% or so. So once again, genotype 3 patients are the most difficult to treat, even in the setting of DAA experienced patients. This is the other Polaris-4 study, which is, as I said, comparable 2-arm study, comparing the triple combination with double combination. And for the first side, you can see that all blue bars are higher than the green bars. So the triple combination for 12 weeks is more efficient than double combination for 12 weeks. And also in details, you can see that overall efficacy is 98% with just 1 breakthrough, but 14 other one relapse from virological reason, and 3 other patients with different reasons. You can see among patients without liver cirrhosis, the efficacy 98, with liver cirrhosis 96%, so extraordinary high efficacy, with details for any other genotype are shown on this slide. I'm sure, ladies and gentlemen, that right now you have in mind just one question about the RAFs, about the resistant variants of HCV virus and their influence on the SVR rates in this kind of study. And this is the graph showing you the summary, so the summary analysis of all these variants. You can see that among the patients with 1 or 4, more than 4 RAFs, which are listed right here, RAFs detected at the baseline, at the entry of or at the beginning of the treatment. So you can see that the extraordinary high SVR 100, it seems just the more variants, the more efficacy. I don't believe this. This is just a question of quite low numbers or any other reason. So extraordinary high without without any influence of numbers of RAFs present at the beginning of the treatment. And these bars are showing you the particular analysis of any detected RAFs, any detected mutations in these regions of viral genome for these 3 genotypes. 4 to 6 are grouped into one analysis. And you can see that even in the patients with the most risky combination of RAFs, So the patients bearing the RAFs in NSA3 and NS5A regions, the highest, the efficacy is quite high, 97. In all other groups of RAFs, the efficacy in genotype 1 is about 98, 99, 100%. So incredibly high, even in this very difficult to treat setting of patients. So this regime, triple combination, sofosbuvir, velpatasvir, voxilaprevir, for 12 weeks is very effective in this setting of patients with RAFs. And last two slides, ladies and gentlemen. I will conclude with the recommendations of EASL, European Association of Study for Study of Liver, which were published just 3 or 4 weeks ago in Paris. And these recommendations reflect all what I have said up to now. You can see the table. You can see the table, which is with recommended regimens for treatment-naive as well as for treatment-experienced patients without liver cirrhosis, non-cirrhosis. And there are only 4 regimens listed for this setting, for this group of patients. And there are 2 regimens used for the patients with this criteria for 8 weeks, gleca-pip, glecaprevir, pibrentasvir, which is brand name Maviret by AbbVie, and the other one is Harvoni by Gilead Sciences. But in some specific group, even in this setting, the patient should be treated for 12 weeks. So the only one pan-genotypic regimen, with 8 weeks treatment duration, with just one exception for treatment-experienced genotype 3 patients, no cirrhosis. The 8 weeks is sufficient for the treatment of naive patients, I mean naive in terms of DAA combinations. And the last slide, the last table, is the same table, treatment-naive, treatment-experienced patients, and patients with liver cirrhosis, and the same, almost the same table, just only the difference is that 12 weeks and 16 weeks for genotypes 3 and 12 weeks for all other genotypes for glecaprevir, pibrentasvir combination, and sofosbuvir, velpatasvir, voxilaprevir is just like a salvage therapy in this setting of DAA naive patients. This is not the first choice for this setting of patients. This regimen is the first choice for DAA failures, which are not listed in this slide. Thank you very much for your attention.
Thank you very much, Peter, for an excellent lecture. The results are fantastic. The whole story of hepatitis C takes about 28 years, since 1989 to 2017. So the story is finished. From my point of view, it's a miracle. What you will do in near future, after 5 years, 10 years?
You mean personally or hepatology itself?
Both.
Both? Hepatology will focus, I think, on the NASH and things like that, or similar, this group of diseases. Personally, I will focus on hepatocancerogenesis and autoimmune liver disease.
Okay. The lecture is open for discussion or comments. Someone, hand on the right.
Thank you for your brilliant lecture. My question is, what would you recommend for the double failures? For those several patients who virologically fail after the previous failure to DAA? Thank you.
Very nice question, but I don't believe there are some data right now published in the literature in this setting. So,
what would be your recommendation? What would you do?
You know, I will go back into the past, and I would treat this patient with twice as long with a triple combination than for the first relapse, like Softwell walks for I don't know, 24 weeks, but just my impression, it's not recommended, it's not written, it's not described right now.
Would you add ribavirin in this setting?
Good question. I like ribavirin, which is the difference against the authors of the recommendations, especially in EASL recommendations. So maybe this would be an option also. Yeah. But you know, the idea of this recommendation is to forget interferon and to forget riba. There is one specific group which I have not showed you when there are two regimens, and the one disadvantage of one regimen is containing of riba, and this, but the results and the price is comparable. And they prefer riba-free regimens. So this is like for discussion in the future or on the each country's level.
So thank you very much, Peter.